Chapter 19, Intraoperative Care. Historically, operations took place in the operating room. Now many are done in an outpatient setting, and these increased of minimally invasive surgeries include things like endoscopies, robotics, and other advanced technologies. These minimally invasive surgeries lead to decreases in blood loss, decreased incision size, pain, recovery time, and a decreased length of stay within the hospital. The surgical department is a controlled environment designed to minimize the spread of pathogens and allow the smooth flow of patients, staff, and other equipment for safe surgical procedures. It begins in the unrestricted zone. This is where people in street clothes are allowed to interact with those in scrubs attire, and it's the point of entry for patients, staff, and information, including things like the preoperative holding area, the staff locker rooms, the nurses' station, and other administrative areas. From there it would move to the semi-restricted zone, and this is where surrounding support areas and corridors with only authorized staff are allowed, and should wear clean surgical attire, including scrubs, long-sleeve jacket, dedicated shoes or shoe covers, surgical head covers, and appropriate PPE. And then from here we move to the restricted zone. This is the surgical suite itself, with a sterile core, and masks must be worn at all times. Path to surgery would begin in the preoperative holding area, an unrestricted zone, where patient identification and assessment is performed. This would also include the admission, observation, and discharge unit. This is where early morning admissions occur, outpatient surgeries, same-day admissions, and the inpatient holding for before the surgery. In our first case study, MC, a 56-year-old male, comes to the surgical suite with his girlfriend the morning of his scheduled surgery to replace his left knee. He has a diagnosis of osteoarthritis of his left knee, as well as a history of hypertension. Whereas the operating room itself is a restricted zone, geographically, environmentally, and aseptically controlled, and its preferred location is next to the PACU or surgical ICU, and is located to provide for quick transport after the surgery with close proximity to the anesthesia staff. The physical environment within that operating room is controlled in a variety of ways, including with filters, controlled airflow, positive air pressure, temperature and humidity control, UV lighting, and strict protocols for cleaning. All of the equipment within this environment is adjustable, easy to clean, and easy to move. The equipment is checked frequently to ensure proper functioning and electrical safety, as fires are a major danger as well. The lighting is designed to provide a precise view of the surgical site, and a communication system is used for quick communication should an emergency arise. There are many different nursing roles within the perioperative staff, including a registered nurse who works with the rest of the surgical team, between preoperative RN, an ORN serving as the patient advocate during surgery, and a post-anesthesia care unit, PACU RN. A scrub nurse follows designated surgical hand asepsis, gowned and gloved in sterile attire, and prepares and manages the sterile field and instrumentation, whereas a circulating nurse remains in the unsterile field, facilitates progress of the procedure, and keeps documentation. An LPN or surgical technologist may fill the role of circulating or scrub nurse. An RN must supervise the LPN or surgical technologist at all times. And the surgeon, a physician who does the surgery and is responsible for preoperative medical history, physical assessment, directing preoperative testing, postoperative management, obtaining informed consent, and leading the surgical team. The surgeon's assistant can be a physician, RN first assistant, a PA, surgical resident or fellow, medical student, or a certified surgical first assistant, and they hold retractors, help with hemostasis and suturing, and may perform some parts of the procedure under the surgeon's direct supervision. The registered nurse first assistant must have a formal education and works collaboratively with the surgeon, patient, and surgical team. And certified OR nurses or nurse practitioners can complete the certified nurse first assistant program and become certified. Continuing our case study, the anesthesiologist meets with MC in the holding area. The purpose is to assess and obtain informed consent for the general anesthesia to be provided during his surgery. Another key member of the surgical team would be the anesthesia care provider, and their role is to administer anesthetic agents and manage the vital life functionings during the perioperative period. The anesthesiologist has a own unique medical specialty, And there is also nurse anesthesiologists, CRNAs, which is a highly sought after form of nurse practitioner. During the preoperative assessment, we need to provide baseline data, including a psychosocial assessment to provide physical and emotional comfort to the patient, as preparing for surgery could be very difficult for some. Before the surgery, we need to review the patient's chart for a thorough history and physical examination, urinalysis, CBC, serum electrolytes, a chest x-ray, or ECG. When admitting the patient, provide an initial greeting, obtain proper identification, and a supportive welcome to the setting. That proper identification is key. We actually had a hospital system here in Northeast Ohio who transplanted a kidney into the wrong patient. So accidents do happen, and positive identification is crucial. When MC arrives in the holding area, he appears anxious and answers questions with reluctance. He shares that this is his first time having surgery and reports pain of 6 in his right knee on a scale of 1 to 10. When admitting the patient, this is the time for careful reassessment. Provide last-minute questions, ask about valuables, prosthesis, and last intake of food and fluids, confirm ordered preoperative drugs, and cover the patient's hair. When admitting the patient, complementary and alternative therapies may also be considered to alleviate the patient's anxiety, promote relaxation, and reduce pain. The circulating nurse is responsible for implementing the intraoperative plan of care, including ongoing assessments, reassessments, and adjusting the care plan to best promote the surgical outcomes. When dealing with room preparation, we want to prioritize privacy, prevention of infection, and safety. We also want to make sure extra staff and special equipment that may be needed for the transfer of obese patients, and special equipment that may be needed for each unique surgery. For room preparation, all entering OR must wear surgical attire. Electrical and mechanical equipment needs to be checked for proper functioning, and aseptic technique must be strictly practiced when operating and placing equipment. All items are counted to make sure that everything is accounted for and nothing accidentally gets left in the patient, and that the scrub nurse is sterile and the circulating nurse is not. When transferring the patient's transported into the OR after the preoperative assessment is completed. The wheels are locked during the transfer between the beds, and enough staff for safe patient handling, safety straps, as well as monitors, leads, blood pressure cuff, and pulse oximeter are applied. MC will soon be transported to the OR for his procedure to begin. His left knee is marked by the surgeon, and he has an anti-embolic stocking or IPC on his right leg, an IV of D5 half-normal saline infusing in his right hand, and cefazoline 1 gram IV after the insertion of a urinary catheter. Scrubbing, gowning, and gloving can be a long process. For wet scrubbing, the fingernails are cleaned first, then each next plane of fingers, palms, and forearms, distal to proximal, with the hands held away from the surgical attire and higher than the elbows. Waterless alcohol-based agents may be used in a pre-wash hands and forearms with soap. Apply this alcohol-based product and rub until dry. After surgical hand asepsis is also key, including sterile gown and 2 pairs of gloves. Once gowned and gloved, sterile items are then touched and organized. Strict aseptic technique is followed at all times, with the center of the sterile field being the site of the surgical incision, and only sterilized items are allowed within the sterile field. OSHA guidelines are standard and transmission-based precautions, engineering and work practice controls, and using personal protective equipment. The assisting anesthesia care provider understand the effects of the anesthetic agents and know the location of emergency drugs and equipment. The assisting anesthesia care provider also works with the circulating nurse and may provide monitoring devices on the patient. Remain at the patient's side to ensure safety during general anesthesia, including measuring the blood pressure, helping maintain a patent airway, and providing vital communication for the provider to the other members of the team. The patient should be carefully positioned to allow for accessibility to the operative site, administering and monitoring the anesthetic agents, and maintaining a patent airway. The patient should be positioned to provide correct musculoskeletal alignment, prevent undue pressure on nerves, skin over bony prominences, and provide for adequate thoracic excursion. When positioning the patient, we also must keep in mind and respect needs such as previously assessed pain or deformities. Secure all extremities, and provide adequate padding and support, as well as having physical and mechanical help if necessary. Keep in mind that anesthesia blocks the sensory nerve impulses, and position changes affect where the pooling of blood occurs. Hypovolemia and cardiovascular disease can further compromise the patient's status. Correctly place the grounding pad and all electrical surgical equipment to prevent injury from burns or fires. There are a lot of videos online of surgical fires, unfortunately, as many of the anesthesias can be extremely flammable. MC is transferred to the OR table, and the circulating nurse begins to prepare him for surgery. When preparing the surgical site, mechanically scrub or cleanse around the surgical site with antimicrobial agent. Scrub from clean area to dirty area and allow to fully dry. The surgical site is then draped. With MC positioned for surgery, the circulating nurse begins to prepare his leg for surgery. There's going to be a lot of safety considerations, everything from infection, physical trauma, physiological effects of the surgery itself, and proper and clear communication being essential. Within the holding area, prophylactic antibiotics within 30 to 60 minutes before the surgical incision. Apply a warming blanket, and applying intermittent pneumatic compression devices to prevent thrombosis. National patient safety goals require a pre-procedural verification process, including verification of relevant documentation, the results of any diagnostic studies, the needed blood products, implants, or other special equipment is available, and that the procedure site is clearly marked by the surgeon. After surgery, the anesthesia care provider participates in the end of the procedure and gives proper types of doses of anesthetic agents so that effects will be minimal at the end of the surgery. The provider also goes with the patient to the PACU, handoff including the patient's status and the procedure done, along with a thorough report of any special needs the patient would require. MC's surgery is now completed and he's transferred to the PACU. He has a drain in his left knee, his left leg is wrapped with an elastic bandage from the ankle to the thigh, and he has a non-rebreather for oxygen mask on at 10 liters per minute. His IV continues to infuse at 100 milliliters an hour. Anesthesia. Anesthetic techniques and agents are chosen by the anesthesia care provider in collaboration with the surgeon and the patient. Contributing factors include the patient's current physical and mental status, their age, allergies and pain history, the expertise of the anesthesia care provider themselves, and factors related to the procedure. The American Society for Anesthesiologists provide a physical status classification system. This is ranging from 1 to 6 and represents patients immediately before surgery, with a status of 1 meaning healthy and a status of 6 meaning brain dead. Moderate to deep sedation may be done with procedures outside of the OR, and the presence of the anesthesia care provider is not needed, and may be administered by the RN under direct supervision of the physician. Monitored anesthesia care may be used for diagnostic or therapeutic procedures done in or outside of the OR, and includes varying levels of sedation, analgesia, and anxiolysis. These must be administered by the anesthesia care provider, and including the assessment and management of any physiologic problems during their care. Then we have general anesthesia. It's a total IV anesthesia. May also use newer inhalation agents, and is used for procedures of significant duration, the need for skeletal muscle relaxation, require uncomfortable operative positions, and require control of the ventilation. General anesthesia would begin with the IV induction agent, and the beginning of all routine general anesthesias may be a hypnotic, anxiolytic, or dissociative agent. These are used to induce sleep rapidly and last only a few minutes. Inhalation agents may also be used. Keep in mind these are volatile liquids or gases that enter the body through the alveoli. They're easy to administer and have rapid excretion. Some are irritating to the respiratory tract, and once initiated, use ET tube. Complications include coughing, laryngospasm, and other secretions. General anesthesia is rarely limited to one agent. Adjuncts include drugs used to the anesthetic regimen and synergistic or antagonistic effects. There may also be dissociative anesthesia, which interrupts associative brain pathways while blocking sensory pathways, such as ketamine. Opioids may also be relied upon to provide sedation and analgesia, the induction and maintenance intraoperatively, and pain management postoperatively. Monitor carefully for respiratory depression, however, with all opioid administration. Adjuncts to general anesthesia may also include benzodiazepines to premedicate for amnesia and provide induction of the anesthesia. Neuromuscular blocking agents may be used to facilitate endotracheal intubation, relaxation and paralysis of the skeletal muscles, and the interrupted transmission of nerve impulses. These neuromuscular blocking agents are classified as depolarizing or non-depolarizing muscle relaxants. The duration of effects may be longer than the procedure, and reversal agents may not be effective in eliminating the residual effects. When using these neuromuscular blocking agents, observe closely for airway patency and adequacy of respiratory muscle movement. Lack of movement or poor return of reflexes and strength may indicate need for a ventilator. As nausea may be expected with a lot of these anesthetic agents, antiemetics may be provided prophylactically to prevent nausea and vomiting. Local anesthesia may be used to provide loss of sensation without the loss of consciousness of the patient. These will take many different types, including topical, ophthalmic, nebulized, or injectable. Regional anesthesia or blocks may also be provided by injection to the central nerve or group of nerves. These nerves that innervate a site remote to the point of injection and used as preoperative analgesia during surgery and after the surgery itself. Local and regional anesthetics have many benefits, including little systemic absorption, helping with rapid recovery, discharge with continued postoperative analgesia, and no accompanying cognitive dysfunction. Regional anesthesia, however, may have certain disadvantages, including possible technical problems, discomfort at the injection site, inadvertent vascular injection leading to a local anesthetic systemic toxicity, which would include symptoms like confusion, metallic taste, and dizziness, and in most more severe cases, seizures, coma, or dysrhythmias. Topical anesthesia may take many forms such as creams, ointments, aerosols, or liquids, and should be applied 30 to 60 minutes before the procedure. And local infiltration, this would mean injecting an agent into the tissues through which the incision will pass. When using a regional nerve block, the RN may aid the anesthesia care provider in administering this block and must be familiar with drugs, including the methods of administration and their adverse and toxic effects. Also, they're there to ensure proper positioning of the patient, monitor vital signs, oxygen therapy, and other supportive devices. Spinal anesthesia would involve the injection of local anesthetic into the cerebrospinal fluid in the subarachnoid space, usually below the level of the L2, and this would have effects on the autonomic, sensory, and motor blockades. Here on figure 19.6, we have a diagram showing how that spinal and epidural is provided in between the spine reaching the central nervous system. An epidural block involves the injection of that local anesthetic into the epidural space and does not enter the cerebrospinal fluid. It binds to nerve roots as they enter and exit the spinal cord, and these sensory pathways are blocked but motor fibers remain intact. For spinal and epidural anesthesia, observe closely for signs of autonomic nervous system and blockade, including bradycardia, hypotension, and nausea and vomiting. There are going to be many gerontologic considerations we should take into account, including the anesthetic drugs needed to be carefully titrated, the postoperative delirium, possible communication difficulties, risk for injury from tape, electrodes, warming and cooling blankets, and certain dressings. Also consider osteoporosis and osteoarthritis and the risk for perioperative hypothermia. For anaphylactic reactions, the anesthetic agents, antibiotics, blood products, and latex may cause allergic reactions. We should have careful vigilance and rapid intervention if necessary. Symptoms include hypotension, tachycardia, bronchospasm, and pulmonary edema. Malignant hypothermia is another danger. This rare disorder is characterized by hyperthermia with skeletal muscle rigidity. It's an autosomal dominant trait and is inherited hypermetabolism of skeletal muscle, resulting in altered control of the intracellular calcium. This leads to muscle contractions, hyperthermia, acidosis, and hemodynamic and cardiac problems. Succinylcholine, especially given with volatile inhalation agents, is the primary trigger. Other factors include stress, trauma, and heat, and usually occurs during general anesthesia, though may also occur within recovery. Malignant hyperthermia is diagnosed after ruling out other causes. A rise in body temperature is not an early sign and can result in cardiac arrest and death. Definitive treatment of the condition is prompt administration of dantrolene. Helps to slow the metabolism. We also need to make sure we're providing 100% oxygen and actively cooling the patient. We also need to take careful family history to hopefully anticipate this condition. Teach patients with malignant hyperthermia that family members may consider being genetically tested. Audience response question. During admission of the patient to the holding area or operating room before surgery, the perioperative nurse must A. Verify the patient's understanding of the risks of the surgery, B. Ensure the patient's identity with a formal identification process, C. Prepare the skin by scrubbing the surgical site with an antimicrobial agent, or D. Perform a preoperative assessment with the patient and physical examination. And that answer is B. Ensure the patient's identity with a formal identification system. I don't want to say the hospital's name, but it was in Cleveland 3 or 4 years ago. And yeah, a patient was waiting on a kidney transplant. And the hospital system actually received the kidney, called the wrong patient in, and transplanted that kidney into the wrong patient, which meant the patient that needed a kidney to live now doesn't have a kidney, and another patient now has the wrong kidney implanted within them. During the administration of any regional anesthetics, it is most important that the nurse A. Monitor for ascending neurologic depression and unconsciousness, B. Ensure that airway equipment, emergency drugs, and monitors are immediately available, C. Monitor the patient's response to the anesthesia, including assessing the extent of loss of sensation, and D. Ensure that reversal agents such as anticholinesterase are available in case of respiratory arrest. And that answer again is B. Ensure that airway equipment, emergency drugs, and monitors are immediately available. Anyway, that is all I've got for you in this. I will see you in postoperative care.